Well, those were a lot of numbers. Trying to absorb other information myself, but I think one of the key things that we want to take from that past lecture is we need to get our money, right? So we have to start by collecting our money. And one of the key parts of the discussion that I want to have today is really how are we doing that? Where are we bringing in our income? How are we working to secure the income that we've earned? We don't want any more than what we've earned. And we want to make sure that we're doing that quickly. If you look at the numbers of how much money is lost in your first few years of practice, 50,000, 100,000, 200,000, 300,000, lost because of just not understanding the fundamentals of coding, the fundamentals of documentation, the fundamentals of the reimbursement process, you could have secured that money and then reinvested. So what was that number? 1-800-TAX SAVE, so on and so on. Just think about that. So today what I want to do is talk about the fundamentals of coding, and keep in mind that this is an open discussion. Any questions at any time, please feel free. Key problem here is I don't know how to work this. There we go. So just to give you a little background, I've been doing this for over 30 years. I started when I was 12, so you can calculate it from there. I have made just about every single mistake you could possibly make, and I've learned from it. I have had a billing company that I sold 2 years ago, and we were only focused on spine. I do education and training throughout the country. I'm considered a subject matter expert. I've done AAPC, I've done NAS, I've done ISAS, and so on. I am a patient advocate as well as a physician advocate. So our goal here is to help you, help yourself, work through the problems that you have on a regular basis in the most open, honest forum that we could possibly have. This disclaimer says that anything I don't know I can make up, and if we're okay with that, I can continue, because I think I've earned that. So we're going to talk about the process of coding. We're going to focus on CPT. There are many rules and regulations out there. Everyone's trying to figure out how they're supposed to code, how they're supposed to get paid, how they're supposed to argue their point. So what we want to do is we want to go to the source. And the source that we'll be using is CPT. We will be touching on some CCI edits. We will be looking at some of the problems that you're facing now as far as documentation in your op note, but also pulling back to your pre-authorization process, the language that you're using, the terms that you're marking down, the little little check boxes now that you have to do in your pre-authorization process. How do we code? There is really a strategy here. If anyone has taken the time to read the CPT book, if your life is that boring, that you've taken the time to look at how the sequence is put together, you'll understand that there's actually a process. My life happened to be that boring, so I read it. So what we want to do is figure out how we're going to implement the coding process as it stands in CPT, and actually put that into our notes, put that into our HCFA form, put that into our reimbursement process. Because if you're not following the process the right way, I guarantee you that on the other side, they're locking down your claim, they're locking down your pre-authorization process, and they're keeping your money. Bottom line. There are 4 items that we have to look at in spine, excuse me. And if we're not following this very basic process, I can guarantee you that you are undercoding. In all of the years that I've done audits, I've done claims reviews and so on, I can tell you that less than 1% of the spine surgeons out there are intentionally overcoding. If you're not following a process, a methodology every single time, you are going to undercode. So if you look at the CPT book, the way that spine is set up, which is different from all other specialties, is that it has 4 different items that we have to focus on. And we really have to focus on it in this order. It's diagnosis, approach, location, and procedure. And we call that DALP. And we do training throughout the country. And when we're doing training throughout the country, in order to keep this as simple as possible, we use the DALP method. What is the diagnosis? What is the approach? Where is the location? And what procedures are you doing? Have you ever really thought about your cases like that? Usually you have a form, it's a little mishmash, or someone else has set it up, or you don't have a form and you're scribbling. If you set up a form that is just like this, for all of your procedures, I guarantee you that you will document appropriately, you will have easier reimbursements, and you will win far more appeals than you're winning now. Diagnosis, approach, location, and procedure. Why, how, where, and what. If you're not answering those 4 questions clearly, the insurance carrier is holding your money. The insurance carrier is denying your authorization. And your staff certainly cannot code properly, because if they can't find the answers to these questions, they can't code. If you're coding and you're not clearly answering these 4 questions in your op note, you're not coding properly. How many of you do your own coding? How many of you know how to code? And I don't mean that in a facetious way. How many of you have actually studied coding? That's how you get paid. That's where your money is. That's where your livelihood is. If you don't take the time to learn how to code, your staff is not going to do it either. If you don't take the time to learn how the methodology of why, how, where, and what, you can't challenge your staff. You can't help your staff. You're not part of the process. So if you're not going to do anything when you leave here, as far as changing your methodology of work, what you need to do is go and look at the CPT book, just the spine section, and understand the why, how, where, and what. Talk about code order. How many of you code on your op note? Oh, please don't. Don't do that anymore. Don't do that anymore. And I'm going to tell you why. When you're doing your dictation and you're coding and you're talking faster, and people interrupting you, they have no respect for your time, let's be honest. You're trying to get things done and you go to the next case, or you have 3 or 4 op notes that you have to get done and people are knocking on the door, your phone is ringing, and you're trying to get it done, and you can transpose numbers. If you're coding on your op note and you don't really code correctly, or you've transposed a number and you want to go and fix that, you have to do a change to the medical record, which is an addendum. You cannot just cross that off anymore. The system is so bad. The sequence of events of getting a claim paid has become so complicated that any change on an op note is considered a need for an addendum. And what does that mean? It's a change in the medical record, which also helps legally if there's a lawsuit, change of a medical record. If you're coding on your op note, please stop. You can code on a separate sheet. You can have those codes sent to your coding people, but don't code on your op note. So when you're coding, also, do you look at the list of the way that you're putting the sequence in? The way that I code is decompression, fusion, instrumentation, grafting. That's just my sequence. It doesn't matter where the case started. Obviously, we're starting with our pedicle screws, and we're going through our decompression, then we're going through our fusion, our grafting. But from a coding perspective, I always code the same exact way.
Why do you put decompression before fusion when fusion pays more?
Because it doesn't really matter. And I'll tell you why I do it that way. For me, you can do fusion first. Whatever your methodology is should be the same way every time. I do decompression, fusion, instrumentation, graft. Always have done it that way. My husband was a spine surgeon, orthopedic, so I don't know why I do decompression, maybe to piss him off, I'm not sure. But I do decompression, fusion, instrumentation, and graft.
Well, I'm sorry.
And I'm going to go to the RVUs on that.
Well, the reason why I code it that way is because the insurance companies, if you put the lower paying code first, they just accept that and pay you people.
Well, that's what they want you to think.
Okay.
So you can put fusion, instrumentation, grafting, and then decompression, but there's a reason for the methodology of not doing highest decompression code or highest fusion code, then highest decompression code, then additional level code, then another additional level code, then an instrumentation code. Could you see how complicated this is becoming? The propensity of dropping a code is so easy when you're doing it based on RVU. Can you imagine the amount of time your staff is spending trying to figure out what order what it goes in? Now, to be totally honest, I didn't know that there was supposed to be an order. I had no idea it was higher RVU and so on when I first started. When I first started, there was nobody out there that did spine. I started so long ago that there weren't even pedicle screws, to give you an idea, okay? So, the way that we coded was decompression, fusion, grafting, instrumentation. All of the add-on codes are attached to the primary code. Decompression code 63047, 63048. Fusion code 22612, additional level fusion code 22614. Instrumentation code 22840, 22842, whichever one it was. And then graft. You reduce the error rate by such a significant amount that you don't have to worry about whether or not they have the add-on code with the primary code. It's on this form, it's on that form. You know what changed? This thing called computers, it's able to get all of this in order. So if you're doing it based on RVUs, you're wasting a lot of time, Your staff is wasting a lot of time. And the way to code it is, I'll start with fusion, instrumentation, graft, decompression. All add-on codes directly below the primary procedure code. Why? Because if you send in a claim, and you have all of your primary procedures over here, and you have all of your add-ons here, the possibility of them getting all the add-on codes and losing this other claim is very common. Everything is denied. So save yourself a lot. You could do just do 10 cases and see if what I'm saying is true. You'll find that they will pay it in the proper order, and the RVUs will be paid in the proper order regardless of how they're set up.
What is the problem?
It depends on your contract. It depends on the carrier. So you can have RVUs based on Medicare. Usually the fusion codes do pay higher. But for the way that we teach, the way that we train our staff is decompression, fusion, instrumentation, graft. And whatever way you want to turn it around is fine. If you're going to do fusion first, make sure you have all your grafting, all your metals, because those are the add-on codes, and then you decompression. I'm fine with either one. Actually, if I do it backwards and I start with fusion, I screw myself up and have to do it all over again. So it's become a way that we've been coding. You also will have less mistakes. You'll capture the proper number of units, because just by muscle memory, when you look at your code set, you're going to say something's missing, something's wrong. I have an interbody fusion, but I forgot my implants. Or I forgot my graft codes. Just muscle memory will teach you that you're missing something. And also, even if your staff is not trained in knowing the actual procedure, they will learn the code set by muscle memory, because you're consistent every single time. So when they tell you that you have to put them in the proper order, those are people that don't do billing. Those are people that do consulting and haven't done billing for a long time. I've never used that order. I've never used RVU order. And we've never had a problem with the wrong multiple procedure reduction. And I have done probably 80,000 appeals in my lifetime. And none of those appeals were the wrong RVU order. So save yourself some time, but also reduce your errors, because normally you'll forget something if you don't have a format. Let's start with diagnosis. We always start with the diagnosis as our key driver. If you're not starting with your diagnosis, you are going to undercode. And in Spine, we have 4 choices for diagnosis. And the CPT codes actually give you that information right in the descriptor. So it's lesion, neoplasm, deformity, or spinal condition. You guys know what all of this is. But for the lay people in your office, they have no idea what this is. How many of you know the name of the billing manager in your practice? How many of you know the biller that works under the manager, that name of that person? Okay, ladies and gentlemen, these people are running your life. They're going to decide how much money you make, whether you like it or not. One of the things you want to do is get to know who they are. The second thing you want to do is you want to teach them, because they're making your money. I don't care if you do 400 cases a year. If you don't know that person, if you don't speak to that person, if you don't meet with that person, you have no idea how much money you are losing. Get to know them. Be nice to them. Teach them. Spend time. One of the other things you want to do is ask them for every EOB that has a 0. Obviously, your surgical EOBs are going to take priority. Every EOB that has a 0. And you want to know why. Because the power of 0 is going to drive you to figure out either you're coding wrong, documenting incorrectly, or they're not collecting. So we don't want to look at the person. It's not the person, it's the process. But what we want to do is say, I need all the EOBs that have a 0 so I can learn, and then you can educate. This is a team effort. If you don't know the person on that team that's sitting on your bench, you have a problem. So you need to be able to teach them the difference between these diagnoses. Now, the reason that it's here, neoplasm, lesion, deformity, and spinal condition is anything that's not in the top 3. That's as simple as you keep it. I'm a simple person. I like the KISS method. It's always worked for me. I have my DALP. I have my everything is in spinal condition if it's not in the top 3. And that's how people learn. We don't have to make this complicated. I can make it very complicated. We don't get anywhere. So when you have people that are coming into your office and they want to intimidate your staff or they want to do an audit and people lose their jobs. That's not helpful. That's hurtful. So here we want to train and educate. DALP, primary diagnosis. If you have more than 2 diagnoses, you're telling me more stuff than I need to know. If you have 7, you're giving the insurance company a way of saying, I ain't paying for any of this because it's someone else's fault. 1 diagnosis as the primary, maybe a second. If you're getting into 3 and 4, you're talking too much. Keep it simple. 2 diagnoses. The main diagnosis is going to be the driver. Is it a neoplasm, a lesion, a deformity, or a spinal condition? Simple. 2 examples here. We have a lesion for laminectomy, a laminectomy for lesion other than a herniated disc, and then we have our standard laminectomy. How many of you have ever used code 63267? 63267. It's laminectomy for lesion other than a herniated disc lumbar spine. None of you removed synovial cysts? Osteomyelitis? You're not using that code? Sorry, sir? Epidural abscess. As long as it's not a neoplasm, it's not a spinal condition, we know it's not a deformity. 63267 pays more than 63047. How many decompression codes do you think there are? 12, 22, 40, 50?
It's less than 10. I would guess less than 10, right?
Oh, we'll talk later. There's over 80. You know what the problem is? We don't turn the page. Got to turn the page. The coding opportunities for decompression are tremendous. We're going to get into that a little bit. But 63047 versus 63267, 63267 pays 25 to 45% higher than 63047 in most cases.
But it's a regional. Like if you do
Yep.
2 levels, let's say you're doing 2-level decompression, you can only bill 63267.
We're doing 63267 for regional code. Patient has a lesion, has an infection that goes from L2 to L5, yes, 1 time. Patient has stenosis at L3, large synovial cyst at L4, 63047, 63267.
No, I agree.
So let me ask you, then ethically, if I did an L1 to L5 and an epidural abscess evacuation, would it not be more, would not pay more if I coded 63047 and 63048 times 4?
You could code 63047 and 63048 times 4, but it's incorrect coding.
So you wouldn't advise that?
I would never advise that. Here's what I see in coding. When you start manipulating coding, you actually lose at the end. Because if you have to start appealing and you have to start fighting and you have to start saying, wait, did I really code that the right way? What game was I playing? We're very aggressive appealers. If we can't appeal it, we won't code it. But when we code it, we're appealing it and we're going to push it. So the reason that I say to code it the right way is because you want to fight every single fight. I don't want to have to worry about who I'm fighting. I don't want to have to worry about what I've written down. I don't want to have to worry about what game I was playing because there's not enough money playing the game the right way. And yeah, there'll be people that would say, well, you know what? It was an abscess, but it was some stenosis there and so on. You have to figure out what game you're going to play. I have one here and then one behind. Yes. Go ahead. Yes.
I have one question. I apologize to talk about this already, or you're going
It's
to talk
okay.
about it later. But it pertains also to Innovasis, because it's something that drives me nuts. If you put a standalone cage in where the instrumentation...
Oh, we're going to get to that.
You're going to get to
We're going to get to standalone cages. We're going to beat the crap out of that. Yeah.
It drives me insane.
Yeah, it should.
Yeah.
It should. You know what should drive you more insane? That if you go back to the code change that was made with 63075 and 22554 to 22551, you cut 18% automatically. When you went from 22630 to 226 and 22612 to 22633, 26% cut automatically. You didn't do anything except go to work. Right? And now we have our 22853 and our 22851, 50% cut automatically. You didn't do anything except go to work. So yeah, we have a lot of problems here, and the thing is, what are we going to do about it? But no matter what the game is, we still can't manipulate coding to solve it, because that's not the way to solve it. Yes, sir?
So if you have a 2-level decompression, and you have, let's say 3, 4, 4, 5, you do a laminectomy, and then you do a discectomy at 4, 5. Okay, so 63038 would you code it as 63048 for the next level, or can you use that code, 63267?
Okay, disc can never be used as 63267. So 63267 is for lesion.
Okay.
A disc is 63030.
Yes,
So you have 63047 for your stenosis at L4. You have a disc at 5-1.
correct.
63030 59 modifier. And now the reason they're using a 63030 59 modifier is because you have a laminectomy. I'm sorry, you're doing a laminotomy for disc herniation. You must have a disc herniation. It cannot be a revision at 63042. If you don't have a disc, if you're not pulling out a disc, if you're not saying I yanked the disc, if you're not saying I found the disc, you can't use 63030. Right? I would not use 63048.
So what do you use for the next level?
63047 for my stenosis, 63030 59 for my disc herniation.
Even though they're both primary codes?
They're both primary codes, 59 modifier, two different diagnoses. So we're diagnosis driven, two spinal condition diagnoses. When they're putting that on the form, you're going to have your stenosis. Your 63047 must have stenosis. Your 63030 cannot have stenosis, and it must be a disc herniation. So if you put down I did a disc and the patient had stenosis at that second level, you just kicked out 63030 and it's 63048. And I'm talking almost as fast numbers as you are, so I'll slow down if it's going too fast. But 63030 can only be used purely for disc herniation and nothing else. And that's a rule that came out, and that's the way that it is. And we fought it, and for revisions and so on, we lost. 63030 must have a disc herniation. Yes, sir.
But in the primary diagnosis, you should be listing the levels, so it helps the coder determine, stenosis at this level, disc herniation at this level.
Absolutely.
So
You don't want to give too much and confuse people, but when you're talking about using two different primary codes for a specific reason, you want to be clear. You don't want to be, overstating it, but you want to be very clear. And when you're documenting it, you're getting to your 63047 conversation in your op note, and then another paragraph. Ladies and gentlemen, paragraphs are very powerful in the reimbursement process, and especially powerful in the appeals process. If you're doing run on, you have to stop and say, next paragraph. I then began my interbody fusion procedure. I then began my decompression procedure at this level, whatever it is. Run on is brutal when it comes to trying to do an appeal. And if you don't have very, very strong coders, they're going to get lost, totally lost. So 63030, not common, happens occasionally. But if I saw that on a regular basis, I'd go, come on, who are you kidding? Come on. And it gets hard to fight the fight when you're messing around. And you need your staff to be secure in what they're arguing for you. So
may I ask you?
Yes.
Not an uncommon clinical situation where the disc herniation is so big, you have to do a 63047, and you are pulling out disc, and it is stenosis. That is the main problem. So can you then, is that proper to code that as 63047? Or because of the fact that you pulled out disc, you must stay within the 63030 realm?
no, once you're getting to the fact that the patient has a stenosis, whether it's based on the fact that it's such a huge disc herniation plus some stenosis, once you get the word stenosis in there, you move to 47.
What about
Yes.
63030 bilateral?
63030, 50 modifier, yes. So the reason that, it goes back to the reason that you must have a disc herniation, it has to be on both sides, that would be bilateral disc herniation, is because when you get paid for 63030, one side, and then 63030 on the other side, you get paid too much money. If you were using stenosis, this is how it goes back to the argument that you were overpaid for that. So 63030, 50 modifier, you must have bilateral disc herniation. And the same thing with recurrent disc herniation. You have to have a recurrent disc herniation. It cannot be recurrent stenosis. It has to be recurrent disc herniation. Okay? So, the other thing that we have to look at is whether or not we are coding correctly for our neoplasms. Because when we're doing corpectomies, we have the choice of corpectomy for spinal condition and corpectomy for lesion/neoplasm. That's combined into one category. And there is a significant amount of undercoding that's done by way of not going to the higher level because of a lesion or neoplasm when you're doing corpectomy. We have other issues with corpectomy, we'll get into that later, but right now what we want to do is making sure that whatever our diagnosis code is, that we are selecting the right code with the descriptor that has either spinal condition or lesion or neoplasm. Because again, you're at a 25 to 45% reimbursement disadvantage if you don't code to the highest level possible based on the diagnosis. So everything that you're doing in coding starts with your diagnosis. Don't start with your procedure. Most people start with the procedure and then they'll throw the diagnosis in last. The diagnosis is the driver. It brings you to the codes that you need to be in. And there's no way around that. Main approach.
Can I ask you one question?
Sure, yeah, anytime.
You said you kind of want to limit it to one or two diagnoses, but if you give the example of the patient has stenosis at one level, disc herniation at another, and spondylolisthesis at a third, or maybe that same, because you're going to want that diagnosis for your fusion coding and instrumentation. Should we list all three of those? For instance, 4 or 5 stenosis, 5-1 spondy with a disc herniation. I'm picking it up, but
I'm okay with 3, as long as it makes sense. So you have stenosis, disc herniation, spondylolisthesis. That makes sense,
okay.
right? But when you start to get into, some back pain from way back when, some cervical pain from over here, from herniated surgery people get in, you'll have 12 diagnoses. Why?
Okay.
So spondylolisthesis is relevant, especially in a degen process type of case, right? It happens. If it's not relevant to what you're doing, then do you need it? So when you're getting to your 3rd diagnosis, is it just filled or is it necessary? So you have to think about that. The reason I put these approaches up here is because even in your discussions, you have a lot of different approaches. But in spine, we still have 3. So when we go to the coding book, we don't have all of these other approaches. We have to figure out what you're saying, where the patient is positioned, and what code choice we're going to use. And the thing is, we don't want to start getting into all these unspecified codes, because then we know that the power of 0 is going to be there, because you're not going to get paid. And then you have to start doing your appeals. But we really technically only have 3 choices. The key to the approach is that it is where you make your incision, not where you end up. So there's no posterior corpectomy code for us. It doesn't exist. But I've seen op notes that said I did a posterior corpectomy. I'm like, no, I don't think so. I don't know how that's possible. And then you get to, I did an anterior interbody fusion from a posterior incision. No, you didn't. You did a posterior interbody fusion, and you pushed up further. You pushed towards the anterior part of the spine. But for us, it's where the cut is. That's the approach. So when you're dictating, be very clear about your approach, because that's how we code. That's one of the 4 elements of coding. Yes, sir. Did you have a question?
Yes.
Yes.
We do corpectomies from a posterior approach.
Well, how are you getting there?
How?
Yeah.
Exposing from the posterior approach, taking the facet, the pedicle, taking the
Are you doing laterally? Are you going more lateral? You're in the lumbar spine?
posterior approach.
Transpedicular approach, right? So there's a transpedicular, but it's posterior.
It's posterior.
Posterior. But you're coming and you're doing a transpedicular decompression. That's what it's called in the coding book. But there's no posterior code in the coding book.
It's technically for coding, it's extracavitary, it's a lab.
Yeah, there's extracavitary lateral,
I know what
there's,
you're saying,
but
that's-
there's no posterior corpectomy code for us. So when you're saying that, your code is saying, I don't have a posterior corpectomy code, I don't know what you're talking about.
So how the code is going to code that? Extracavitary?
It could be an extracavitary approach, it could be a transpedicular transfacet approach, and that's why you really need to know what the descriptors are. There's the costovertebral approach. There are some, I'm not saying that you can't go posterior and go anterior, but what I'm saying to you is that there's no posterior corpectomy code for us. No. But if you're doing extracavitary lateral, there's a code. If you're doing a transpedicular, there's a code. But these words matter, because the person on the other side that's throwing this claim through the scrubber is going, no way, you can't do it, can't pay you, not going to win that one. And now you just started off a series of appeals.
But if there is transpedicular corpectomy code,
There's a transpedicular decompression code, but it's not a corpectomy.
Yeah, it's not a corpectomy code, it's just an approach code. It's not a-
so what you use for a corpectomy?
You don't use
Extracavitary.
You can't code a corpectomy.
So then you have to use extracavitary even though it's not a
Lab
lab
code
code.
costotransversectomy, because you're in the extracavitary.
Yeah.
So it.
But you have to say it.
Every single word that you're putting in there is being scrutinized, every single one. And even when this stuff is clear, I can't find the instrumentation. Could you read paragraph 2, page 2, paragraph 2, line 3, 4, 5? It's right there. Oh, well, that's the 5th appeal. Oh, know how much time that took? Know how much money that cost you? So know the language. That's what this is about. Know the language. Anterior posteriors, lateral posteriors. Are you doing 2 op notes, or are you doing one when you do it on the same day? If you're doing 1 op note on the same day, I can tell you that you're getting underpaid. Your payment is underpaid, it's delayed, it's appealed, and there is a really hard time for people to go in your billing office to collect that money. 2 op notes, stage 1, stage 2, clear as possible.
Well, what if you put that in the, like I always say, stage 1 anterior, stage 2 posterior?
Yeah.
I mean, but it's one of them.
Yeah, but I'm your advocate, and I'm telling you I don't want it. I'm fighting for you. So now what happens is that it goes in 1 op note.
Well, I'm asking this
Well,
because
I'm
I'm
gonna-
specifically discouraged.
I
used
know.
to do that, and they say, no, that's not 2 operations, that's
I know.
1 anesthesia. And
No, that's not true. The reason that they don't want you to do that is because they'll tell you that you'll get overpaid, which you don't. They'll tell you that it's confusing and that the other person won't know that there's a second procedure. This is all about educating your staff. And the other thing is cost, because of transcription. When you put your anterior posterior on 2 separate op notes, what happens is this. The coders can differentiate the anterior and then the posterior. Then they code the anterior. Then they code the posterior. Now, they could send it in as 1 claim. There's nothing wrong with that. Medicare, you have to send it in as 1 claim. Commercials, you don't. But when there's a denial, they can focus right on where the issue is. When you put that together, anterior instrumentation versus posterior instrumentation versus the implant versus the fusion versus the decompression, too many ways to deny your payment. Anterior procedure, posterior procedure, you can submit it as 1 if that's what they're concerned about. That's probably one of their concerns, that you're unbundling. But definitely easy to post, easy to code, easy to post, easy to appeal. Yes, sir.
So question, I had a scenario like that you just 2 separate up notes,
Mm-hmm.
but if you don't look over your up notes, they can send only the anterior. But the person that's coding for you
Yes.
doesn't know that you.
Yes.
So if they just send the anterior, they will bill something, but they will totally not bill your posterior.
Well, you have to have a way of communicating. This also goes back to knowing the names of the ladies, and they're usually ladies in the back room. I call them the girls in the back. There has to be a way of communicating. This is stage 1, this is stage 2, there are 2 cases, whatever it is. And you know, you guys and ladies do the same cases over and over again. You're not really, shocking us with something new maybe every once in a while, but we're creatures of habit. You like doing anterior posterior, they should know your technique. They should know what you like to do. And if you have an anterior and you always do posteriors, that person should say, wait, shouldn't I be looking for a second case? That's how they get to know you. So if you're training them to look for 2, they should always look for 2, as opposed to maybe look for 2. And in the case where there's only 1, they should be asking you, is there a second one, when you've always done 2, or you authorize 2. Or this is procedure 1 of 2, right on the top of your op note. Hopefully they're reading, but I will tell you, they're not reading that much. They're not reading enough. But there has to be some way of communicating that. And then you should also be looking to make sure that those have gone out properly and that you have your 2 op notes. So that is something that you do have to be careful of.
Because
Yes,
we're
sir.
talking about op notes, can you clarify a falsity or it is a truism? If you did the same procedure anterior posterior the same day versus anterior 1 day posterior the next day, is there a financial difference in that?
Yes. You get paid more if you did it 2 separate days. The reason for that is that there's a multiple procedure reduction taken. It's a calculation that's put in for all primary procedure codes. If you want, your top primary procedure code is paid at 100%. All of your additional primaries are paid at 50%. If it's staged on the next day or 3 days later or whatever it is, or a month later, that does not happen. All your primary procedures are paid in accordance with the rule. On the first day, first primary procedure is paid at 100%. All other primaries are paid at 50%. Add-on codes are paid at 100%, no reduction. When you get to your next day, 2 days later, 3 days later, first primary code is paid at 100%. All other primary codes are paid at 50%. The post-operative clock restarts. So you'll have your 90-day post-operative period that restarts, but there's no reduction on that, let's say usually the posterior primary decompression or fusion. It's paid at 100%. Yes?
What about RVUs? It's not the same as the way you get paid, the RVUs are, but they also drop, don't they?
RVUs just dropped again, yes. What they're doing in spine is they're doing little tiny increments, guys, little tiny, tiny little bits.
I saw, I asked for a breakdown of one case where we had done same day A-lift with the general surgeon, T3 to pelvis, and at the end of the day, what I walked away with from A-lift was, I think, 8 RVUs or some of,
Yeah.
pretty disappointing.
Yeah, yeah, I would have been crying. That was a T3 to the pelvis? Yeah, I would have been crying.
But they didn't give me the screws. Like, it was just, it was.
Yeah, when you do your A-lifts and your posteriors and you have a general surgeon in there, you're lucky you could buy coffee when you're done. Yeah. So that's a killer. So try to avoid it. Do a lateral.
How do I
Do a lateral and a posterior, do 2 different days. Yeah, do a lateral.
But
Yes,
isn't
sir.
that where you could do the two-up though? So does your general surgeon stay and do your posterior pedicle screws fusion with you? Because
No, but he doesn't get the posterior.
No, they don't get the posterior. They're only getting the anterior fusion code. It's still a killer because you have the co-surgeons getting half of that. Then you get a multiple procedure reduction on that. So really, it costs you more money just to get dressed and do that anterior part.
So better to do it on separate.
Right, yeah, it costs you more money in gas to get there than what you're gonna get paid. It's bad.
Although the co-surgeons, are they not getting paid 80% each of the primary code or no?
The co-surgeon gets paid usually 60% now of the primary code that you are using for your fusion. Brutal, brutal. Yes, sir.
So I have 2 questions. So if you have an unplanned return, so, or let's say you
Yes.
have anterior,
Yep. Well, when we're saying stage, that is a planned return. But just hold me right there. When we're talking about a planned return, we're talking about something that you said we're probably going to do 2, we might even do 3, might even do 4. We're not talking about complications, all right? That's not a plan. If you're planning that, we have to have a different discussion. We're talking about a true plan, doing anterior, posterior, anterior, posterior, anterior, anterior, whatever it is, a true plan. Sorry, go ahead.
yeah, so your plan was to go anterior, but something happened, maybe the bone is crappy, and then you say, okay, 2 days later, I'm gonna back it up posterior. How does that change your up note, your codes, your reimbursements, number 1? Number 2, when you flip in posterior and you do those T3, T9 to pelvis, do you use the arthrodesis code, like 22802, or do you go to 2612, 2614 times 9?
I'm not going to have to finish my whole thing because I'm going to go through all my points, but that's okay. That's a good question.
It's based on your diagnosis. Your diagnosis is
Well,
deformity. And you have to build a deformity code.
Technically, not really. Technically, if you go through the SRS and you go through Medicare and you go through all of, yeah, so I used to do it that way. I believe that if I had a kyphosis or scoliosis, I would use the deformity codes and I got killed. Nope, nope, nope. If the patient had degen scoliosis, if the patient had stenosis, if the patient had spondylosis, spondylolisthesis, that is not a degen. I mean, that is not a deformity. A deformity is a kyphosis, idiopathic scoliosis, neuromuscular scoliosis, and so on. It's not a kyphosis from a fracture. It's not a degen scoliosis from flat back or degen from an aging process. A scoliosis is a scoliosis. SRS has articles on it. Carriers are following that. And if you are doing a revision, it's not a deformity. But there's very limited use for deformity.
It's also helpful to list each level in your fusion, not T3 to the sacrum.
Yeah, that's here too.
T3
That's it. I won't even have to do my slides. We got it all.
T6, so they kind of code for each segment, basically.
Yes. So the deformity has become a problem. And in some cases, some carriers will only let you do up to 12. Medicare, it's 14 levels for a non-deformity fusion. So we call it line item fusion for the simplest way of teaching coding. It's a line item. It's not a bucket fusion that we would use in deformity. But you must have a true deformity diagnosis as your primary diagnosis in order to code any type of deformity.
Right, so the argument is if you have degenerative scoliosis, the argument is you're fusing them not for primary indication of deformity, but for primary indication of their degenerative spinal pathology.
Right.
So to your point, the argument is you have to be very certain that your documentation for your diagnosis bears that it's a degenerative condition and not a deformity condition, which is one of the things that we spend all this time learning about deformity parameters and talking about deformity indications. Sometimes we kill ourselves because then you can't bill it as a degenerative fusion.
Yes. And when you have the combination of procedure, when you have a degen and a deformity, such as many of the slides that were up here, and you're coding that as a deformity, really you're killing yourself in reimbursement because it's far less. And it doesn't include the sweat factor of all the decompression work that you have to put in there, all of the malalignment that has to be worked through, all the osteopenia and osteoporosis, all that sweat factor is lost in the deformity code, in the deformity reimbursement. So unless it's a true deformity, stay away from it. You could have an adult scoliosis that they had as a child and it was never corrected, that would be a deformity. But not if the patient came in after having deformity surgery, now has flat back, now the rods have to come out and so on. That is a degenerative process. That's a line item fusion. Okay? So, we talk about the language here. This is the language that we have. So these are the words that we have for our approach. These are not my words, these are words from the CPT book. And depending on the word you use, will depend on for corpectomy here, will determine what code I'm selecting. So we have to be very clear about how you're getting there, because there are different subsections within the approach that we have to use. So if we don't see the word retroperitoneal, we can't assume that we know that the coder knows that it was a retroperitoneal approach just because you're at L5S1. We can't assume that. And we're not going to assume even further that the carrier is going to say, oh, no, I know what they meant. I'll take care of that. We're going to pay it. They're going to pull it out. They're going to hold it. You're going to have to appeal it. You're going to have to fix your op note and so on. This is the new game. This is how it is. Posterior, these are the choices that we have. Now, we use A-lift, T-lift, PLIF. We use all the O-lift. Do you think that anybody in your office knows what they are? They don't know what it means. They don't know what the T stands for, the L stands for, until someone tells them what that means. So those acronyms are not in our coding book. They don't exist for us. So unless you're going to be clear about the approach, a PLIF means nothing, unless you tell me that it's a posterior approach, a posterior lateral approach. A T-lift means nothing, unless you tell me it's a transpedicular, transfacet approach. It means nothing to the coder. And it even means less in the coding book because that's not how it's written out. Conservatival is pretty obvious, but again, depending on the word that you use there will determine the code set. Usually the higher you go in the code set, the more money you make. So that's important as well. And we have extracavitary lateral. There is no cervical. If we did one of that would be called a decapitation and a lawsuit, so stay away from there. So you have your thoracic and your lumbar. There's a discussion about whether or not you're supposed to use the extracavitary lateral approach versus the anterior lateral approach. And really, that's a NAS issue, and that is now carrier-driven. The carrier will decide which one you will use. So make sure that you're aware of what their rules are. 22558 versus 22533. Make sure you know the rules before you even send your claim in. You can look them up. The more you are prepared in advance, the more likely you'll get your money faster. These are the code sets that we have. Main location. So in coding, we need to know where you are. Not like the general area, not where you were hanging out. We want to know where you were, who you were sitting with, where you were sitting, exactly what type of seat you were sitting on, what you were drinking while you were sitting on that seat in order for us to code. So you get the picture. I want to know exactly where you were. Because I'm not supposed to figure out. I wasn't there. And the carrier certainly isn't going to do that for you. So a T5 to L3 fusion is not a thoracolumbar fusion. And do you know how many op notes I see like that? And I'm like, wait a minute, where the hell were you? Where were you? Exactly where you were. Because the way that we code is based on counting. And yes, I still count with my fingers. I have not come up with a way after 30 years of trying to do this in my head. I still have to do T1, T2, T2, T3, T2. I still have to do that. I don't know anybody that could do that off the top of their head. But if you're not exact about where you are, they're not going to be able to figure it out. This is probably the most important slide you will see today. Sorry, guys, but we're talking about money. A comma and a dash. C3-4, interspace. C4-5, interspace. C3, comma, segment. C4, comma, segment. I know exactly where you're working. And in the descriptor of that CPT code, it tells you whether you should be billing it by interspace, by segment, by level. And you would know that if you read it. And it's very important. This comma and dash changes the world. Coders can code better. Carriers will see clearly where you were. And then they know how to code based on what the descriptor says in the CPT book. A comma and a dash. Interspaces versus segments. When you're doing your procedure portion of your op note, a comma and a dash. Laminectomies, corpectomies, interbody fusions, lateral fusions, where were you? So that the person that's coding can count, because that's what we do. If you're not using this, you're undercoding by one segment or one level on a regular basis. Go back and look. Look at how you're dictating. Look at how you're noting. In this case, we have a discectomy and a corpectomy. Not clear about where you are. Spondylosis, disc herniation from C3 to C6. I'm not supposed to figure it out. You're supposed to tell me. If I see this situation right here, I cannot build a discectomy with the corpectomy because they're bundled together. If you're clear about where they are, I can code. C3-4 is the interspace discectomy. C5, comma, C6, corpectomies. I can code those. I know that this seems a little elementary, but you'd be quite surprised at how much you don't put in your op note. Interbody fusion, posterior fusion, laminectomy. I'm not supposed to figure out where you are. I can't go into the op note and say definitively, this is where you are, unless you tell me exactly where you are. And I'm not supposed to guess and code like that. So here you have your laminectomies, your interbody fusions, and so on. And we know we'll get into the laminectomy discussion with the interbody fusion. But when you clear this up, everything else starts to fall into place. How many interspaces do I have implants? How many levels will I have instrumentation? That's what I need to know.
I'm sorry, can you go back to the slide?
Sure could.
So isn't that L3-4 laminectomy and L4-5 laminectomy? So isn't that two-level?
No, because laminectomy is by segment. It's not by interspace. It's not by facet. The laminectomy is by the laminectomy level. That's the descriptor. So I did a laminectomy at L4, and I did facetectomies at 4-5. That's how you describe it. You can't do a laminectomy at 4-5 because there's no laminectomy in 4-5. It's a laminectomy at 4 or a laminectomy at 5 or a laminectomy at 4 and 5.
So the discectomy is by interface, and not only that, laminectomy is by vertebral body then?
It's not vertebral body. It's by segment or level. Somebody has the book. They can look it up. It's one or the other.
But the way we do decompression, we don't do an L4 laminectomy for L4-5 stenosis. We do an L4-5 laminectomy for L4-5 stenosis.
You can't do an L4-5 laminectomy. There's no laminectomy at L4-5.
It's an L4 laminectomy.
It's not L4 laminectomy, L4 lamina, or an L5 lamina.
So in other words, all we gotta do is just take a couple of bites of L5 with the
Eh.
and now we have.
Partial laminectomy of L4 and partial laminectomy.
Right, and that's how you would say it. You would say partial here, full, you could say full and complete depending on what you've removed. I can't answer that because I'm not there. But if, say you do a full laminectomy at 4, I know you want to make a comment, I'll be right there. And you do a little bit of nibbling on 5, no, you wouldn't be coding 5. But the
You did a laminectomy at 5.
But you're getting paid for a decompression, a laminectomy, facetectomy, foraminotomy, decompression of this root, this nerve root, now one. If you have to take a little bit of 5 to finish a decompression, it's not billable.
Also, how much do you have to take to be
Usually it's at least half.
But how many of us ever do an
At least
L4-5
half.
laminectomy, not do a partial L5 laminectomy, because you gotta go down a little bit.
Well,
Yeah, it
you
takes a
actually
lot
go
of
by
time.
nerve
Yeah,
roots.
my son is to make it a perfect
Go by
square.
roots.
You go by nerve roots.
Well,
But
the
I-
code is not by nerve roots though, so you have to be very careful about how you're describing it too.
But you
Right.
say a partial laminectomy of L4 and a partial laminectomy of
Right.
L5 with foraminotomies of the L4 and L5 nerve root. That way they understand I decompress 2 levels.
That's 2
Is
levels.
that a 63047 or 63048? Or is it
Yes.
63047?
That's a 63047, 63048.
But again, back to your point, that was just a partial laminectomy.
Yes.
But a laminectomy does not have to be full and complete, both sides done. That's not what a laminectomy is, but I do want to point to someone here, I'm sorry, sir.
She said it to
So,
be
the
50%.
problem that I'm having now, you know, and maybe this is throughout the country, but, and maybe you're gonna get to this with doing a transfemoral interbody fusion.
Yes,
But if you're coding for spinal stenosis and for spondylolisthesis, you do the laminectomies, you do the.
we're going to get to that.
interbody fusion,
Yep.
For the spondylolisthesis, and they are bundling, they're trying to
Mhm.
bundle the laminectomies with the
Yep.
TLIFs.
Yep.
And
But
no
I-
matter what we were trying to do to try to handle that, it's still a big zilch on it.
It is a big problem. But just to focus on what we're talking about, the laminectomy, because it is going to come out and the discussion is going to be, what can I code, what can I code? So the way that you described it was the perfect way to describe it in your op note, so thank you for doing that for me. I appreciate that. Now, what's happening though is that we do want to get that second level, and I'm going to take off a little bit of here, but you're not giving me that decompression. You're getting paid for the decompression. The laminectomy for decompression is the code. And it is key now that you put the nerve roots in. It is key that you start describing out further than you ever had to before for the pool of idiots that are reading it. That's what it is. That got your money and they're not giving it to you, right? I mean, they got your money and I want it. And it's a great game and they're winning. But if you're describing partial L4, partial L5, vasectomy for amyotomies and so on, nerve roots decompressed, beautifully decompressed. They were pulsating. They were, I don't care what they were doing, but they're decompressed. They were pink. I don't care. Tell me the story, because when I have to do the appeal, that's what I have to highlight. I have to highlight that for my 2 levels. This is happening every single day in your office. I don't care if you're contracted with every carrier. It's happening every day. You want to meet the most miserable bunch of people in your office? Go into billing. I don't know why anybody does it. It is miserable. And these are the things that we're talking about, because we're fighting for a 63048 for $234 that just cost you $800 to not get. It's brutal, brutal job.
Barbara, can I maybe add a Kevin?
Yes.
You're asking a typical L4-5 landing. I'm assuming the patient has L5 radiculopathy, lateral recess stenosis. That's what you're decompressing centrally in the lateral recess, correct?
And you never go up and decompress L4.
Correct.
Right.
So in that case, Barbara, if you're just decompressing centrally and the lateral recess where the L5 nerve root runs, or maybe others could chime in, then you would just code 63047.
Despite the fact you took both 4 and 5 partially.
Well, tell me what you took. So, because we have a 4 and we have a 5 going on here, so I think we have 2 different things. You just said, no, that's fine. You said a central. There's a central decompression code, so that's why I'm pointing to that.
Yep.
And then, if you go out laterally, what happened? Tell me what happened.
You take part of the facet.
You can't just say that. What I'm saying to you, if you're just saying I took part of the facet, they go, nope, not getting paid. I'm reviewing your case. I am on your side, but they're not. What did you do? And you see how ridiculous this game is? It is ridiculous, but this is what we're playing. So tell me what you did.
You did lumbar laminectomy, mesophaseectomy, and foraminotomy of 1 nerve root, but you took part of 2 lamines.
I want to know where you did the laminectomy. Laminectomy is a level. It's a bony level.
You have L4 and L5.
I did a laminectomy at L4. Did a facetectomy at L4-5.
Yes.
I did a decompression of what nerve roots?
The L5 root, yes.
What did you do at 5?
You took part of the lamina.
How much?
A third.
It's gotta be 50%.
Yeah, if I was looking at that and I only have 1 nerve root decompressed, I have 1 facetectomy, I only have a third, I'm going, no, just 1.
If you make your
Well, that's a
laminectomy,
foraminotomy code, isn't there a foraminotomy?
No, you wouldn't be able to do that because you want to talk about the foraminotomy at L5?
Yeah, that's what.
And the stenosis is at L4 or 5?
Well, no, well.
You see, and I'll tell you something.
Well, the stenosis is of the L5 nerve root. So what I do in those cases is, usually that facet overgrows up
Yes.
into the foramen of L4. And so you're taking off the entire facet, not the entire, but the medial half of it. But then I look at the L4 nerve root with the foraminal probe, and I nibble away the superior aspect of that upgoing facet. So I say
There you go.
stenosis of the L4 and L5. I've decompressed, I partial laminectomy L4 and L5 with decompression of the L4 and L5 nerve.
This thing is driving me
just take
crazy.
your
You
laminectomy
can-
high enough to go to 4.
Right.
Take
You
a little
can-
more
you
L5,
can-
let's move on.
You can undercode if you want, but that's the way the game is played. You've done both.
Main procedures, we already beat up decompression a little bit here, so just going to touch on, all right, your procedure portion. This is your purchase order. This is where you start. Don't skimp on it. This is what people are reading. This is what you did. However you want to do it the same way, the same way you're coding, the way you dictate. Before you start dictating, could you go back and look at what you had authorized and make sure that you're dictating in accordance with what you had authorized? Because if you change that, you have to go back and do an appeal and get all new authorization. It's ridiculous, I'm telling you. The whole system is crazy. So list out everything you did, and the coders will have to figure out what's bundled. Decompression codes, we're here. I'm going to tell you this here. This is the most complicated coding in all of spine. If you can nail that, you can do anything else. But here's the other part. You could have 1 case, 12 coders, 13 opinions. So at the end of the day, you have to be able to appeal whatever you're coding. That was our mantra. If we can't appeal it, we're not coding it. That's how we did it. So whatever your comfort level and what you're documenting, make sure that you can appeal it. And make sure that you can win 80% of the time. Otherwise, you're overcoding. So this is the most complicated coding that's out there. The language matters. You need, bless you, you need to make sure that you are reading the descriptor and following it verbatim. And that's how you get paid. There are several types of decompressions that can be done during each session. Your coder is not supposed to be figuring out what you're doing. Make sure you list them out, and we'll figure out what's bundled. Make sure your line items are very clear about the types of decompressions you're doing at certain levels. This is just an example of what's in there for cervical. I already told you there's 80 decompression codes. This is one small example. Let's talk about anterior lumbar decompressions. There's no code for that. If you're coding that on a regular basis, 64999, you need to stop because you will be audited. You may do a lateral decompression from an anterior approach. It happens occasionally. You cannot code an indirect decompression as a decompression. When you do have a decompression, that's legit. You're talking about your nerve roots and so on. Unspecified procedure code 64999. You can't split out your cervical decompression and your cervical fusion. That's 2255. I'm sorry. That's 22551. One code, two. If you have co-surgeons, you got to share it. That's the rule. Corpectomy rule, 50-30 rule. You must take 50% of the cervical spine in order to code a corpectomy. You must take at least 30% of the thoracic or the lumbar spine to code a corpectomy. Now, what does that mean? Does it mean you go in with your little rule and you go, okay, I did this and I'm going to mark that down and I took 50% off, now I could code it? No, that's not what's going to happen. But you can say I removed greater than 50%. I removed a majority of the vertebral body, but be aware of the fact that they will ask for an x-ray to see how much has been removed. They are doing that. Be aware of the fact that they're looking at the size of your implant to make sure that it correlates to a corpectomy size. Make sure that you have in your op note that the patient needed a corpectomy for the several different reasons that you wouldn't have to have a corpectomy performed. Otherwise, they're going to pull your claim. They're doing that because corpectomies were used and abused for a lot of different reasons because we didn't have any other code choice. But be careful of when you're coding corpectomies and look for that appeal. Intradural versus extradural. When you're doing your corpectomies, we have a lot of choices. Are you extradural? Are you intradural? Are you intradural, medullary? Are you extramedullary, and so on? Every time you go up a code set, there's more money. So if you have a lesion or you have a neoplasm and you're doing corpectomies, make sure you're clear about exactly how deep you had to go with that lesion that you performed that corpectomy, because the money matters. Here's our code set for our extracavitary lateral approach. We don't have any decompression codes for extracavitary lateral approach except for a corpectomy. So if you're doing your lateral approaches, doing your decompression, and you're putting in your implants, it's similar to the ALEF code, 22558. You're not able to code 22533 with the decompression unless you're doing a corpectomy, and you're not going to be doing those on a regular basis. That's usually for tumor fracture, something like that. Yes, sir?
So can you use a 63101 through a posterior approach?
No, that's extracavitary lateral. Patient is in the lateral decubitus position.
It's a posterior approach.
We're not, no, we have, if you're not putting that,
Tumor resection from posterior approach, which code does it use? 640?
there are posterior codes for lesion and neoplasm. It's a laminectomy. If you are doing the laminectomy and then you're coming around extracavitary lateral, then you would use this code for extracavitary lateral approach. But you could have the posterior tumor and then the lateral tumor, that you would be using this code. But there's no posterior corpectomy code for us except for this choice. And you don't want to get into unspecified procedure codes because then you just get killed in the appeals process. Posterior overview. Posterior has a lot of choices. And depending on, as we're going through this now, how you get there, how deep you go, what the diagnosis is, and so on, will determine, because there are all these subsections that we can use. If you're not familiar with the 4 subsections, I guarantee you are undercoding if you don't know what's available to you. One surgeon's laminotomy is another surgeon's laminectomy, as we clearly demonstrated here. So watch your language. Watch your language. The differentiator here is the type and depth of the invasion of the lesion or the tumor, when we're talking about laminectomies for lesion other than a herniated disc, because you can go out wide, you can have many levels, you can go extradural, intradural, extramedullary, intermedullary, and you could have an extramedullary, intermedullary combo. So if you're doing that type of work, probably undercoding if you don't know that these codes are available to you. Interbody fusions with decompressions. Here's how you work that. If it is a Medicare patient, Medicaid patient, if it is a Medicare plan, Medicaid plan, you may not code the decompression with an interbody fusion for any reason. They don't care. It's in the CCI. They have spelt it out. Do not 59 modifier it, because what you're doing is bypassing the edit, and there will be audits. Do not do it for Medicare. Do not do it for Medicaid. Do not do it for any replacement plans. They have made it very clear. Everybody else is fair game. How do you win that appeal? How do you get paid? You do your decompression procedure as if that's all you were doing. And I can find that decompression procedure. I can identify it in the op note. And then I go to my next paragraph, and I started my interbody fusion procedure. Patient must have stenosis. Patient must have stenosis if you want to win that appeal. If you're using the transpedicular code, the 63056, 63057, you're probably getting denied and probably won't get paid. 63047, 63048 has the higher level of appeal successes. They're not buying the 63056 and the 63057 transpedicular approach, unless you have a far lateral disc herniation or foraminal stenosis. But even with the foraminal stenosis, unless you're going in transpedicularly, you shouldn't be using that code. Yes? Mm-hmm. We're good? You want me to stop? Okay. Okay. So in this particular case, make sure that you're very clear about how you are noting your decompression and go for the appeal. Fight it. Win it. You will win it. It's going to take like 4 or 5 appeals. But you have to be very clear about that interbody fusion and that decompression. Fusion procedures, what type are you doing? There are several different types. We're not supposed to figure that out. Lateral, deformity, or interbody. Reconstruction, revision, as we spoke about before, versus a deformity, be very clear about that, or as clear as you possibly can so that we could do the right code set. You also want to make sure that in your fusion discussion that you're talking about how you were able to decorticate the fusion area to set the fusion bed. You're not getting paid if you're not discussing the fusion bed procedure. Even if you're saying I put the bone graft in, you have to be clear about that. Make sure that you account for all the types of fusions that you're doing so that the coder can select all of those. There are different types of fusion codes here, combinations and so on. It's become more complicated than it should be, but that's the world that we live in. Deformity, we beat that up a little bit before. Make sure you're selecting the right deformity codes and you're counting correctly. Exploration of fusion. For Medicare, you cannot bill it if it's at the same site of another fusion. For every other carrier, it's fair game. Where you did your exploration of fusion, what you found, and what you decided to do, what medical treatment you decided. You need to answer those 3 questions for your appeal, because you will have to appeal it. Grafting. We don't really know what all the graft codes are, so you have to be clear about the graft codes that are there. Tell us what you're using. If it's a new product, let us know what it is so we could code for it. Most graft codes, autograft, same site, allograft, is not paid unless it's structural or iliac crest. It's become part of our business, we understand that. But there are some carriers that do pay for it, so you want to make sure that you're noting it. And bone marrow aspirate, 20939, make sure you're coding that. You are paid usually for 1 unit, but you want to get paid for the service. Make sure you're using 20939. I'm going to stop here with the fusion unless anyone has specific questions about 22853. I just want to touch on that. Let me get that to you because I don't want to keep you from your bowling. This is available if you'd like to get the PowerPoint. If you have any questions, you can give me a call. MIS. Let me tell you about MIS. If you're doing an MIS procedure and there is no MIS code, you use the open code. There's nothing wrong with that. That's the code you're supposed to be using. You do an MIS pedicle screws, use 22840, 22842, nothing wrong with that. You do an SI joint fusion, minimally invasive, 279, open, 27280. There's a code for MIS. So if there's a code for MIS, you have to use it. If there isn't one, use open. Biomechanical implants, and this is the last thing I'll touch on. The only way that you can code for the plate, I'm going to keep it as simple as I can, is if that plate can be used on any other implant. It is not locked in. It is not screwed into that implant. It sits on the face of the vertebral body. Now, if you're using an implant that you have in 2 different packages, it could be the same company, packaging doesn't matter. Implant is in, that anterior component is locked into that implant, you cannot code for the plate. Okay? Keep it simple again. If you're coding for a plate, it must sit on the anterior component of the vertebral body. It may not in any way, shape, or form be integrated, married, touching that implant at all. Now, be prepared for a denial. Be prepared for an appeal. Product guides, surgical technique guides, pictures of the implant and the plate separate, and a possible x-ray might be needed for your appeal. And that's the only way you're going to win that. So with that, I will be around if you have any other questions, and I don't want to keep you waiting. So I know you want to move on. I'll be around, and I have 2 kids with me, so you could pull me away from those kids at any time you feel necessary. I'll be more than happy to work through your issues.
Thank you very much.
You're welcome. Thank you.